Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started.
Hello, everyone, and welcome to Thinking Thoracic, an STS podcast. I am one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. I am so excited to bring you the latest and greatest in thoracic surgery. One of my favorite things to talk about is clinical trials, and I'm so excited to be bringing you updates and downloads from major oncology meetings and discuss the new treatments and trends that continue to shape how we care for lung cancer patients. Today, I am so excited to welcome an oncologist, an educator, a researcher, and all-around brilliant friend and colleague, Dr. Wade Iams. Welcome, Wade.
Thank you for having me, Dr. Gillaspie.
Wade and I are so excited to get together today to review the exciting updates from the recent World Lung Conference. Wade, the early stage lung cancer space is both so exciting and becoming so complex. There were several presentations at the World Lung, including updates on both the NeoCOAST-2 trial as well as Checkmate 77T. So today we're going to dig a little bit into both of those trials, what was reported at the meetings, and how all of that will continue to shape our landscape. So let's talk NeoCOAST first. For our listeners, would you begin by summarizing the trial and some of the initial findings to help get people oriented?
Yeah, listeners are likely aware of perioperative chemoimmunotherapy followed by surgical resection and adjuvant immunotherapy as a new standard of care in patients with resectable non-small cell lung cancer. Importantly, in Keynote 671, overall survival benefit has finally been shown with the addition of immunotherapy to neoadjuvant chemotherapy, and then following that with adjuvant immunotherapy. So NeoCOAST-2 is a study that's looking at 3 new drugs added to the neoadjuvant part of treatment. The origin of those 3 drugs is a little different. So 2 of them are novel immunotherapies. One is called oleclumab. That's an anti-CD73 monoclonal antibody. The other one's called monalizumab. That's an anti-NKG2A monoclonal antibody. Those 2 studies, interestingly, had some promising phase 2 data in the unresectable stage 3 non-small cell lung cancer space, where when they were added to durvalumab consolidation, it looked like they improved the recurrent-free survival for patients with unresectable non-small cell lung cancer. So that led to the hypothesis that if we add these novel immunotherapy drugs to the neoadjuvant setting, where we're already doing platinum doublet plus PD-1 or PD-L1 inhibitor, perhaps we could see further benefit. Now, NeoCOAST-2 also had another arm involving an antibody drug conjugate against TROP2. TROP2 is a protein that's widely expressed in non-small cell lung cancer. The TROP2 antibody drug conjugates, specifically Dato-DXd and sacituzumab govitecan, have been heavily evaluated in the relapsed non-small cell setting. It's still a question of whether they will ultimately obtain FDA approval in the relapsed non-small cell lung cancer setting. The data was underwhelming in comparison with docetaxel in the randomized trials for patients with relapse disease. Nonetheless, it's widespread target in non-small cell lung cancer. It's clearly an active drug, so the hypothesis for the Dato-DXd arm was that the addition of this active compound for patients with surgically resectable disease could potentially improve our outcomes for perioperative chemotherapy, immunotherapy plus novel agent, followed by standard PD-1, PD-L1, and or novel immunotherapy in the adjuvant setting.
So a lot of really new, exciting treatments. When we saw the presentation, one of the first things they shared was, of course, the first outcome that we're getting from a lot of trials, which is the pathologic complete response. And that gets us all very excited. What made you most excited about the presentation and some of the data that they were able to share with us at World's Lung?
Yeah, it was interesting, and what what was the most striking, I would say, is that the pathologic complete response rate for patients who received Dato-DXd in combination with platinum doublet and immunotherapy was about 34%. Now, we were all very excited when the path CR rate in Checkmate 816, 3 cycles of neoadjuvant chemo IO, was 24%. The path CR rates for our anti-CD73 and anti-NKG2A antibodies were about 20 to 26%. So not significantly different than the 18 to 24% path CR rates we've seen from Keynote 671 and the Checkmate studies, but the 34% path CR rate when Dato-DXd was added is very intriguing. I would call out that's 54 patients who achieved that 34% path CR rate, but that's the number that is the most eye-catching to me. I'm curious, you as well, what caught your eye?
It was the same thing. I was really excited because really the data continues to show us that the patients who derive the greatest long-term survival are those that we get the pathologic complete response on. Really unprecedented survival curves. And so if that's a trend that's maintained as we continue to add more patients, oh gosh, that'd be a really exciting addition into the early setting as we're thinking about treating these patients.
Absolutely.
One of the things that we think about a lot as well is obviously getting every single patient to surgery. With all of these new agents, I don't really see any worrisome signals yet with regards to patient safety. Do you have any trepidation or concerns as we begin to move all of these drugs into that neoadjuvant setting?
Really good question. And when you look at the numbers on the NeoCOAST 2 study, specifically grade 3 or greater treatment-related adverse events, they're 20 to 30%, which is not significantly more than you would expect from platinum doublet plus IO as a whole. I do think it's a little bit higher than you would expect with solely that treatment, but I would absolutely expect a higher rate of toxicity by adding a fourth compound to the systemic therapy in the neoadjuvant setting. Nonetheless, I think these are acceptable rates. I think we're going to touch on it later in the podcast too, but the rates of patients not making it to surgery, obviously not all due to complication, but some of those patients would have had complications with a triplet neoadjuvant regimen anyway. So I do think it makes sense that the rates of treatment-related adverse events are a little bit higher. Fortunately, not significantly higher, on the order of 40 or 50%. I think that would be absolutely prohibitive if that were the rate of grade 3 or greater treatment-related adverse event that we were having, where we're basically hospitalizing that proportion of patients. But it does call in the reality that these are clinical trial patients who have very good performance status, less comorbidities than patients who we're typically treating in the clinic. So that's where the conversation, when patients are diagnosed, between thoracic surgery and medical oncology, radiation oncology, in determining the best treatment course for that patient based on their clinical status initially, I think is such a high stakes decision already, and it's in the future likely going to be even higher stakes.
I think you hit the nail on the head with that. And actually, because you mentioned it, let's dive into that. One of the biggest concerns that I hear at a lot of surgical conferences is, of course, the drop-off rate. We've known about this for a long time, right? It goes all the way back to publications. That I was reading at the beginning of my career, including INT 0139. We know that there's some patients that are going to drop off during the neoadjuvant treatment. And we're seeing that consistently across the trials, usually somewhere in the order of 20%, maybe a little bit less with some of these newer trials. But it always gets me thinking, what are the proactive steps that we can be taking? How can we enhance the relationship, improve the handoffs between surgery, between medical oncology or radiation, if we're incorporating that as well, to make sure that we're not losing patients for reasons that we can control?
Yeah, I think that is always the key question. And I'm of the opinion that multidisciplinary tumor boards are really helpful when we're all together looking at a scan of a patient and talking through their clinical status. I think in an ideal situation, at least one of the physicians on the call has had direct interaction with the patient. So we know what their preferences are, what their clinical status is in person, which is often very different than how a medical record looks. And it can go both ways with the medical record. As you know, it can look very severe and the patient looks great, and the record can look like nothing, and then the patient is not very mobile or really a good surgical candidate when you drill down and talk to them about their day-to-day activities. So it's always a complicated decision-making process. The more information we have, the better, and the more, I would say, coordination between information processing, surgery, and medical oncology, especially, I think the better the outcomes will be.
I love that, especially as the space continues to get more and more complex. And I think the other important thing always to mention too is not all of these patients are being lost to treatment complications. Some of them were unwell to begin with. Some patients changed their mind. There's no question there were some patients who fall off from treatment complications, but there's also some who surgeons re-reviewed their scans and actually said, hey, you know what? Actually, they weren't really resectable. They were pretty borderline. We gave them a treatment. It wasn't very effective in reducing the size, and we really don't feel that they're, great resectable candidates. So I think there's really a variable and sort of a wide variety of reasons that patients aren't always making it to the defined treatment pathway that we're hoping to get them through.
Yeah, and another domain that we run into for patients who don't make it to surgery, and I'm curious your opinion too, is the reality that there's a cohort who just have such aggressive disease that they progress through neoadjuvant treatment. And it seems to me as a surgeon that would be almost, I don't want to say preferable, but a relief to some extent to say, we didn't take this patient to surgery, subject them to this risk when their disease is so aggressive and it's refractory to really the strongest systemic therapy that we have.
Yeah, no, I totally agree with you on that point. And I think that's really important because we know in these locally advanced cases, surgery alone isn't enough. And if our systemic therapy isn't going to work, we know that these patients already have micrometastatic disease. And these are often the patients that you get this 3-month follow-up scan, you're feeling really excited, and all of a sudden they have disease everywhere. And it's so discouraging for that patient, for the family, for us as the surgeons. And so, yeah, absolutely. That's one that I think about a lot. So, do you think, is this just the beginning of neoadjuvant combinations? Do you think the future is going to be all about combinations? How many drugs can we pack into patients before surgery?
Yeah, that's the $1 million question. I think to insert a word of caution and to go back to the number of patients, and you cited this as well, that we need to see more patients treated with the TROP2 ADC and get some more data in the neoadjuvant setting to make sure that 4 drugs really is a tolerable regimen to administer in the neoadjuvant setting, and that the AE rates don't increase, that the PAP CR rates hold at least relatively close to what we've seen so far. I think that could make this a viable quadruplet approach. And there are other ongoing perioperative clinical trials as well, looking to improve upon the outcomes that we have so far. And the reality is, when we have this conversation with patients about the cure rate at the end of the day, it's still not high enough, especially for stage 3 disease. And, having healthy individuals who are in the prime of life have this diagnosis, and you're having to have a conversation about maybe we can give you a 50% chance of cure, it is a really harsh conversation. And I think thinking of that frame of reference, 4 drugs would be reasonable. But obviously, every individual is at a different place at the time of diagnosis. So very different than somebody who has many comorbidities, has already had medical complications of a variety of types at the time of this diagnosis. But curious, your opinion too, as a surgeon, do you feel like we're going overboard at all with the number of systemic agents we're subjecting people to?
I'll tell you, there's no more fun conversation to have with patients than to come up after surgery. I'm lucky. I often get my path back really quickly, like on day 2, and so often I get to share with patients in hospital their pathology results. And when I tell you, I share with patients that they had a complete pathologic response, the tears of joy that they have, the celebration that they have, because we've reviewed, our oncology team members have reviewed those survival curves for them to say, hey, if we can accomplish this in the neoadjuvant setting, your chances of being alive in 5 years are extraordinary compared to if we don't. And so it's very, very exciting. And even be able to share with them that they had some kind of a response is always a huge relief for the patients to know that they did the right thing. And so, while there's no question that it does make surgery harder, some of the fibrosis that we have to deal with, in particular with nodes that have had response around the hilum, can confer, a lot of surgical difficulty. I'm doing a lot more PA reconstructions, sleeve resections than ever before. Every time I'm doing one of those cases, in the back of my mind, I'm sort of celebrating because I know that patients had a great response. So I think of it as a really, really exciting time.
Absolutely. Good.
Any closing thoughts or remarks on NeoCOAST 2 before we dive into our next trial?
I think it's promising. I think, as we've noted, time will tell. We need to see more patients and results and more longitudinal follow-up too, regarding event-free survival ultimately, and overall survival, which will obviously take notably more time to mature from these studies. But I think there's a lot of potential future movement and improvement for these patients.
I love it. Okay, let's jump into another exciting trial, and that is Checkmate 77T. So this is sort of I think it is a sister study to Checkmate 816. As we all know, Checkmate 816 really helped to usher in this completely new era of neoadjuvant, and now it's evolved into periadjuvant chemo IO. Would you be able to give us just a little bit of a reminder? What was Checkmate 816? How is this similar? How is this different from the newer trial that was just reported out, which is Checkmate 77T?
Yeah, Checkmate 816 really launched the field of perioperative, and I should say neoadjuvant chemoimmunotherapy. The semantic difference that a lot of us are integrating into our vocabulary is trying to be a little more specific, with neoadjuvant regimens being only applied prior to surgery, which has always been the definition, but then using the term perioperative, referring to systemic therapy that's delivered both neoadjuvant and adjuvant. So Checkmate 816 really launched immune checkpoint inhibitors into the neoadjuvant space. And it was 3 cycles of platinum doublet plus nivolumab, followed by surgical resection and no adjuvant therapy. As I noted earlier, the path CR rate was 24%. So very exciting rate of pathologic complete response. Event-free survival rates were improved compared to chemotherapy without the immune checkpoint inhibitor. So that has led to a slew of additional perioperative primarily studies where not only chemoimmunotherapy neoadjuvant is administered, but also adjuvant immune checkpoint inhibitor is administered. And at this point, we have 3 FDA-approved perioperative regimens that have followed up. Checkmate 816 was only neoadjuvant. So, of course, we have Keynote 671, we have Aegean with durvalumab, and now we have Checkmate 77T with nivolumab in the perioperative setting, all FDA approved for these patients. I think we're going to get into it a little bit too. But in addition to the distinction that Checkmate 816 was preoperative systemic therapy only, all the perioperative studies administer a checkpoint inhibitor in the adjuvant setting, typically for 1 year after surgery. But another interesting difference, which I don't know how much to make of, but maybe something. So Checkmate 816 administered 3 cycles of systemic therapy before surgery, whereas all the other perioperative regimens, including Checkmate 77T, administered 4 cycles of platinum doublet plus immunotherapy, which, as we know from the stage 4 setting in systemic therapy, that's more standard for what we administer with a platinum doublet to get maximal benefit is 4 cycles. So a subtle difference there in the treatments that were administered, comparing Checkmate 816 with the subsequent perioperative regimens. But interesting dialogue there. I don't know, do you feel any difference between 3 and 4 cycles as far as what you see in patient functional status, or how they tend to tolerate 3 versus 4?
It's funny that you ask that. From a fibrosis standpoint, I don't see a tremendous difference in the 3 versus 4. The responders are going to have more scar tissue than the non-responders. But interestingly, I think patients who get 3 actually come in at a slightly better functional status. That 4th dose really seems to beat people up just a little bit more. And actually, it's not uncommon these days that I get calls from my oncology colleagues saying, Hey, we've snuck in 3. I'm not confident I can get a 4th dose in, but luckily we have this trial to fall back on that we know was highly effective. We had a very good pass CR rate. That pass CR rate wasn't driven up higher by giving a 4th dose. So actually it gives us a lot of comfort knowing that we're actually okay to stop after that 3rd dose. We've still gotten great treatment into that patient. We can get them through a successful surgery and still have a great outcome.
Yeah, that's a really important point too, and relates to a lot of ongoing trial designs for ongoing studies, which are really at least receipt of 3 cycles of neoadjuvant treatment, and not being mandatory 4 cycles minimum. Checkmate 816 is the key foundation, as you cited, to us feeling more comfortable with that practice.
It's funny, you talked a little bit about, really making sure that we're differentiating the neoadjuvant versus adjuvant and versus peri-adjuvant or perioperative. And one of the things I hear coming out of a lot of conferences these days is phase of care, contribution of phase of care. It's something we're hearing a lot from the FDA as well as these clinical trials are being designed and developed, really trying to hone in on which part of the treatment is actually providing patient with the greatest benefit with tolerable, acceptable risk. When we think about Checkmate 816 and 77T, this is really the closest thing that we have to cross-trial comparisons. And there's a lot of people, and the really big part of what we heard at World's Lung was looking at subsets of these patients in these 2 different trials to try to start making those determinations. What do you think about cross-trial comparison for 77T versus 816? And can we start to make conclusions now about how much benefit we're adding with the adjuvant piece of this regimen?
Yeah, I think that is probably the biggest question in the field is when we bring up the debate between neoadjuvant only versus a perioperative regimen and trying to isolate the contribution of adjuvant therapy, the reality is we don't have the head-to-head data, and we'll probably never have the head-to-head data of such a trial. I don't think it would be worth the patient's time. I think it's more worth the patient's investment and everybody's investment in looking at new agents at this point. So while cross-trial comparisons are never ideal, it's all we have. And so I think that it is helpful, the analysis that was presented at World Lung, which directly compared Checkmate 77T and Checkmate 816 and their event-free survival rates ultimately. So looking at neoadjuvant only with 3 cycles versus a perioperative 4 cycles neoadjuvant and immune checkpoint inhibitor for a year adjuvant, event-free survival differences. Now, take what you will, being cross-trial comparisons not done in the exact same clinical context for those patients, but the event-free survival was notably improved in the perioperative cohort. So we were talking hazard ratio differences of about 0.56 to 0.61. So that's a very respectable hazard ratio for any clinical study. Now, cross-trial comparison. So as I've said multiple times, it has to be taken with a grain of salt, but it looks fairly powerful as far as a benefit to a perioperative regimen. You can dig in and say, is it that they got 4 cycles in the perioperative versus 3, because that was a difference as well, in addition to the adjuvant checkpoint inhibitor. But one of the key aspects that you've alluded to already is that it was clear that patients who didn't have a pathologic complete response had more benefit from the adjuvant component, which is intuitive to all of us, but helpful to see borne out in the data.
I agree. And actually, I was surprised to see there was more benefit even for the path CRs than I expected. That was one of my concerns, is that perhaps that was a patient cohort that we were over treating potentially and committing to a year of additional therapy. But it seems to have borne out across all pathologic response, which was really interesting.
Oh, yes. I think it's so hard to say in the clinic when you're meeting with a patient, what is their individual likelihood of benefiting from the additional systemic therapy. And the reality is, even patients with a pathologic complete response, when you look at full populations of patients, some patients benefit. So who are those patients? I think are the questions for the future. That's where I'm always following liquid biopsy technology a lot, as you know. And there we're seeing interesting improvement in sensitivity of those assays to be able to detect residual disease. It's not in prime time to be able to use a liquid biopsy and determine whether to do adjuvant therapy or not. But I hope we get there someday. And I think everybody would be most satisfied with that result. The patients would know there's a definitive diagnostic test. They can tell me that I'm in this cohort of patients who may continue to benefit from treatment or not.
Agreed. And, from a quality of life standpoint for a patient, it's wonderful to be able to keep things as short and as effective as possible. But we also never want to miss the opportunity to help achieve a cure. One of the big, really limitations, I would say, of cross-trial comparisons, and as you've noted, really taking cross-trial comparisons for what they are, and things that I sort of worry about with this specific one is the patients who went on to get adjuvant, I think are perhaps a little bit of a better off subset. So what I mean by that, there are people who tolerated a full neoadjuvant treatment, surgery, and were well enough to get at least one dose of adjuvant therapy. So we're already sort of pre-selecting perhaps a more fit, a higher performance status patient. Is this too great of a confounder to overcome, or is it still that these patients are similar enough that you feel comfortable being able to apply this information to your patients as you meet with them in clinic?
Yeah, it's a huge question. So not being a surgeon, here's my non-surgical opinion. If you're strong enough to get surgery, then you've already met a whole different bar of functionality in the overall scheme of especially a medical oncology clinic. So having cleared that bar, I think that it's fair to compare within that overall cohort. That's definitely an oversimplification. What you said is certainly spot on, that there's a whole degree of tolerance for systemic therapy, recovery from surgery, that are massive physiologic stresses that a person must pass those tests in order to get to a certain place. But what I would say from the medical oncology perspective is, seeing those non-surgical candidates in the full spectrum that they are, it's a very different group than surgical candidates. And if you're able to get to surgery, I think that says a lot and puts you in a cohort that's fair to compare. But curious your opinion too. Do you think that that's a big confounder, or do you think that my logic of if you make it to surgery, that category is reasonably, obviously no category is homogeneous, but reasonably similar enough?
You know what? I felt very similarly because certainly there are surgical complications, morbidity, factors that can play a role in delaying initiation. And for a clinical trial, can actually cause people to fall out, right? Because it's so strict with timing that, if you have somebody who takes a little bit longer to recover, in the real world, as someone we'd still say, hey, this patient can get adjuvant, but on a clinical trial, it actually might take them out. So I actually was a little less bothered by that aspect of it, but I know that generated a lot of conversation at World's Long. Are these fair comparator groups? And I agree. We all deemed them well enough to get through surgery. They all made it through surgery. They just didn't all go on to have adjuvant. So I felt like they were more similar groups than perhaps we were giving them credit for.
Yep.
One of the historic challenges with adjuvant is, of course, completion of treatment. We know that patients have a much higher likelihood of completing neoadjuvant, of getting through that pathway. Often, I think it's because patients are using surgery as sort of the target to get to. They have something they're aiming for, and it allows them to get through that. They get through their surgery, and now they have adjuvant, and all of a sudden they seem perhaps a little less tolerant of some of the side effects, or perhaps a little bit less engaged as we get out closer to that year. What are we seeing with some of these newer trials? Are we getting more and more patients through this adjuvant arm? Are we still seeing a huge fall off? What are your experiences also in practice?
Yeah, there's definitely a fall off. And when you were describing the impact on the patient, I felt like you might have also been describing my usual change of mentality. Because the reality is, in medical oncology clinic, when we're administering a systemic therapy in the adjuvant setting, we know that we're using population data, and there's uncertainty in this individual's case as to whether they're benefiting There's uncertainty over the duration of the treatment that we're administering in the stage 4 setting as well. There's all kinds of uncertainty, also uncertainty in the adjuvant setting. So those thresholds lower for the patient, certainly. And I think in most clinics, they lower for the treating physicians too, the threshold to stop therapy. So when we look at the numbers of completion of adjuvant therapy, I couldn't find it for NeoCOAST 2. I think it's still maturing, and we don't fully have that. But Checkmate 77T, I believe about 60% of the patients completed adjuvant checkpoint inhibitor. So obviously a notable fall off, but I think representative of my clinic for the reasons previously cited. If patients are having side effects and we say you've gotten through X amount of adjuvant therapy, in addition to the surgery that you've gotten through and the neoadjuvant treatment that you've gotten through, enough is enough, and we're going to keep an eye on this. And there is a component of uncertainty there, but in the risk-benefit calculations that we go through in systemic therapy, the reality is these patients may be cured, and we have much greater hesitation to overtreat a cured patient than the reality, and I think it is complex in a stage 4 patient. So it's such a different mentality in that setting. And curious your opinion too. Do you feel like your conversations change pre-op to when you're seeing them post-op and they're going into their adjuvant therapy or on surveillance on their adjuvant therapy? You may feel like all the work you've done is to some degree at stake, especially if they're having some low level side effects and you don't want to see those accelerate.
Yeah, it's so funny because there's so many thoughts that go through my head. The first, and I have to share that it's such a joy that I get to share so many patients with my oncology colleagues, and they allow me to be a part of the long-term surveillance and follow-up. So I get to see a lot of these patients, which has become one of the greatest joys of my career. And it's funny because, we think about this year and change that a patient is going through this treatment for their lung cancer. We're like, oh, it's just a year. But in a person that we're talking about potentially 5-year survival, less than 5-year survival, that's a huge percentage of time. And to be able to commit that to a treatment and potentially forego holidays and events with family with concerns of infection and having to mask up and having their immune system potentially compromised at different times of the treatment regimens really it's a big impact from a patient standpoint. So that's sort of one perspective that I think about, the treatment regimen from. But the other one's when you sort of alluded to in that we don't actually know that a year of adjuvant treatment is a sweet spot. And we actually don't even know that the dosing needs to be every 3 weeks, right? There's some people who, especially with pembrolizumab, are pushing it out to 6 weeks. I think all of us would be really excited if there were more oral tablet opportunities for patients so they didn't necessarily have to come in for infusions. I think as these treatments continue to evolve, hopefully we can come up with more opportunities to have, very patient-friendly delivery methods. There's some sub-Q injections now that are becoming options, I know, which might be better for patients, that they can be delivered at home. So I think the future is going to help us to get more of that adjuvant treatment in, but I'd be really curious about a trial looking into that. Is it 3 months? Is it 6 months? Is it a year? Where are we actually getting the most benefit for our patients in the adjuvant setting?
Yeah, I think that would be a really high yield study. And on the component of subcutaneous administration, I think that's another key potential, even tidal wave, ultimately change in a lot of our oncology practices. The reality that immune checkpoint inhibitors, atezolizumab is the first one to have approval for subcutaneous, and the way the FDA has granted that approval is that it's across all indications for atezolizumab. So I actually brought this up recently with a patient of mine who was on adjuvant immune checkpoint inhibitor. Do we want to change to subcutaneous? It's very individualized. The discussion, this person had more anxiety in general about the treatment going in, and things are going well. So we didn't want to rock the boat and change to subcutaneous, although I don't know, not aware of any data saying that that would be necessarily more toxic. But some patients will want to stick with their regimen that they've been on, and some patients are going to change to subcutaneous. The patient preference data around subcutaneous administration for atezolizumab suggests that about 70 to 75% of patients, when asked, would prefer subcutaneous. So that could be a big change in the outpatient setting. And I think it's very relevant for the conversation of continuation, because time in a healthcare facility is a really important component of decision-making processes for these patients and families and their healthcare teams.
Yeah, absolutely. But you know what? It keeps reminding me exciting times and constant new developments and new treatment opportunities for patients. So, Wade, here's the question of the day. You have a patient who comes in with locally advanced lung cancer. They're ALK and EGFR negative. Please, please, please test your biomarkers, everybody. They underwent successful neoadjuvant chemotherapy, immunotherapy, followed by a successful surgery. Are you doing adjuvant on everyone? Are you doing adjuvant selectively? Are you using the same agent in the preoperative and postoperative setting? I see a little bit of variability of that. How are you structuring your practice today?
Yeah, I would do adjuvant for everybody in that setting, even if they have a pathologic complete response. I think we have data suggesting there's a smaller cohort, but nonetheless a cohort who benefits from adjuvant checkpoint inhibitor, even if they had a path CR. So especially if they didn't have a path CR, I would do the adjuvant checkpoint inhibitor. I have typically used the same checkpoint inhibitor, neoadjuvant and adjuvant. I'm doing a full perioperative regimen. I will say this came to the fore recently for a patient that I have on perioperative regimen currently, where it was actually right after World Lung, where the path CR improvement was clear and was stuck in my mind. And we were all going in hoping for a path CR. And I slipped out that, oh well, if you have a path CR, maybe we won't have to do treatment after surgery. And they just latched onto that. And every visit's like, I'm going to have a path CR, and I'm not going to get any more treatment. And I learned from that, and I'm saying, well, the reality is you may still benefit. So I'm not going to set up that expectation going in anymore. And so I think that's the important thing too, as these changes come out, to make sure we're managing patient expectations. That's what I ran into when Keynote 671 first got approved, and patients had started on Checkmate 816 with an anticipation of 3 neoadjuvant treatments, surgery, and no more treatment. And once expectations are set, you absolutely can change that, but it's much more disruptive to all sorts of aspects, so many aspects of a person planning their life around this treatment than we can even imagine. So I think, to me, that's the key. And for expectation setting, knowing the data, planning a full perioperative regimen is what I would go into. And if there's some reason that that's curtailed, as long as the outcome's still good, everybody can still be happy.
And you know what? That's a place that I feel like we as surgeons can help at as well, is making sure to keep reinforcing that same messaging that we're going to get you through this neoadjuvant treatment. We're going to restage. We're going to get you through a great surgery. And then we're going to pass you back to our medical oncology colleagues to talk about additional therapy afterwards, because we all think it's going to be helpful in this setting. And so continue to reinforce that. I agree. And the same messaging coming from all team members, I think, can become really powerful for patients.
Absolutely. I think, that really bolsters success of the treatment regimen.
Well, I can't even thank you enough for your time today. What take-home messages, what final words would you like to leave our listeners with today?
Yeah, thank you for having me, Dr. Gillaspie. That's really important questions. And I think 10,000-foot view, new immunotherapies or TROP2 ADCs may be coming to the neoadjuvant space. Patient selection is going to continue to be key. Perioperative, I would say, looks like the winner currently for our approach to patients with resectable non-small cell lung cancer. But at the end of the day, the multidisciplinary team, patient and family have to be on board with that aggressive approach to have the best result.
Fabulous. Thank you to all of our incredible listeners. Happy Lung Cancer Awareness Month to everybody. Let's get out there. Let's spread the word about screening. Keep taking care of extraordinary patients. And as always, keep smiling.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.